Abbey Alkon and Asa Bradman. Abbey is a professor at the University of California, San Francisco, with the School of Nursing, and director of the UCSF California Childcare Health Program. And Abbey is a pediatric nurse practitioner and epidemiologist. She has over 25 years of clinical and research experience in the fields of pediatrics, public health, and epidemiology. Her research focuses on understanding how social and physical environment affects young children's health and development. Abbey's recent program of research focuses on environmental health and young children in childcare programs, and she has a new mixed methods study funded by the National Institute of Environmental Health Sciences that's being conducted in 4 San Joaquin counties and is designed to reduce exposure to pesticides for young children in family childcare homes. Abbey is also on the Leadership Council for the Office of Head Start's National Center on Health, Behavioral Health, and Safety. And we also have, as our other featured speaker, Asa Bradman, who's an expert in exposure assessment and epidemiology, focusing on occupational and environmental exposures to pregnant women, children, and farm workers living in agricultural communities. In 1998, he co-founded the Center for Environmental Research and Children's Health at the UC Berkeley School of Public Health, and in 2020, he joined the faculty at UC Merced. Asa leads exposure and epidemiology studies examining pesticides, air quality, flame retardant chemicals, metals, emerging pollutants, VOCs, and other contaminants. He participates in extensive community outreach and education and interfaces with other scientists, state and federal agencies, policymakers, and industry. And he's a past member and chair of the California Biomonitoring Scientific Guidance Panel and finished a 5-year term on the USDA National Organic Standards Board. Asa's worked in agriculture, including harvesting grapefruits and apples for export, taking care of chicken sheds, and was the produce manager for a small grocery store. And Abby, if you want to start getting your slides ready to share, you can go ahead and do that while I make one more little comment here. So today, Abby and Asa are going to discuss their research study about IPM interventions in child care centers, pesticide impacts on persons in child care centers, and resulting IPM efforts from the study. And this is the first time I've invited speakers to talk about this nexus of IPM and childcare centers. So I know for folks in the audience, even if you don't work on pest management in childcare centers, there are many of us who have kids, nieces, nephews, or grandkids spending a lot of time in childcare centers, and many of us who spent time in childcare centers when we were younger. So I think that successful IPM practices at these locations are a really important way to prevent unnecessary pesticide exposures to a susceptible subpopulation. So I'm excited to hear this presentation, and I'll pass it over to you, Abby, and just a heads up that we do have some engagement check questions popping up in the chat related to the DPR continuing education units, but you can ignore those during the presentation.
Okay, thank you. And thank you so much for the nice introduction. So I will also just recognize that Kim Hazard is, I see, attending, and she was our project coordinator on this project. So very happy to have her here. And please, Kim, you can provide some comments or questions as we go along. So I'll move on. So just to mention that today we're going to be talking about one of the studies that Asa and I and Kim as the coordinator just recently finished. And Andrew Sutherland has also been a part of this project, and I think some of you might know his work. This was funded by the National Institute of Environmental Health Sciences. And on this project, we had a nice collaboration between UCSF School of Nursing and UC Berkeley's Center for Environmental Research and Children's Health. And we had, as I mentioned, Kim Hazard, but also another project coordinator, Evelyn Bagini, and many of other people who worked on this project who are childcare health consultants and also research assistants. We've also worked at UC Berkeley with Dr. Bob Gunier and Asa Bradman, who's going to be speaking with me today. For all of our projects, we like to involve the community and to get feedback as we're developing our work. And so in this project, we included the resource and referral agencies because they are really key in the community with connecting and training childcare providers. And they're also very much locally based in each county, so they help us a lot with recruitment too, and dissemination of our findings. We include statewide IPM, we included a childcare director, and people from the California Department of Pesticide Regulation, who we work with very closely. For the background, I'm going to have Asa talk about this now. Is Asa here? I didn't see his name here. I'm just wondering if he's late.
Yeah.
Oh, you're here?
I'm here. Can you hear me?
Okay, great.
Okay.
Yes, great.
So thank you, Sheba, for your introduction, and thank you, Abby, for introducing the project. So my goal for the next few minutes is really to introduce kind of ideas and understanding about why children are more vulnerable to pesticides and other environmental exposures in their environment. So specifically, though, for pesticides, some of the main concerns in terms of long-term effects of even potentially low-level but chronic exposures are cognitive or neurological and developmental changes. You know, we may see children, for example, that don't reach their optimal outcomes in terms of learning ability, or they may have symptoms for ADHD. We've seen that in particular with certain agricultural pesticides and exposure in kids. There's also a number of studies showing that there's associations between pesticide exposure and respiratory outcomes in children, adverse respiratory outcomes in terms of lower lung capacity, and also increased symptoms that you might be classified as asthma. There's maybe some children that have asthma and are more vulnerable, so they're more likely to have cough or other symptoms related to pesticide exposure. Or there may be some evidence that certain pesticides may kind of tip the bucket for a child into a long-term respiratory problem. There's been a number of interventions to reduce pesticide exposure in childcare settings, and we'll have some more background on use of pesticides in childcare a little bit later in the talk. But a lot of these are focused on kind of educational integrated pest management interventions, but have not necessarily actually measured child level exposure. So what we mean by measuring child level exposure can mean a few things, but in this case, we're talking about actually taking measurements of pesticides on surfaces in dust, like carpet dust or house dust, in their environment, or putting, for example, a passive sampler, which you'll hear about more in a bit, on their wrist as a way to see what kind of pesticides they're contacting in the environment. Next slide. So one of the kind of intuitive things that we all know is that children are more vulnerable than you know, especially very young children are more vulnerable than older children or adults, of course, to things in their environment. And this is very important when we talk about exposures to chemicals or other environmental contaminants. Children eat, drink, and breathe more per kilogram of body weight. So I know many of you have had kids. I know I did, and they're little. You're worried, oh, they're not eating anything. They're actually eating a lot more than you do for their body weight. So if there's any contaminants in their food, for example, or drink, they're actually getting more of it in their body for how much they weigh. They also have a lot of behaviors that increase exposure. They spend a lot of time on the ground or floor. So if we have things like pesticides or in other environments, you know, lead paint dust or things like that, they're contacting it on the floor and on surfaces. And children, especially young children, have thinner skin and it's more absorbent to chemicals that can absorb through the skin, and they have more surface area for their body weight, so they can have more dermal absorption exposure. And they also have a lot of behaviors that increase exposure. So of course, you know, little kids, hand to mouth activity, you see the child in the picture there putting something in their mouth like a toy, or actually maybe that's a food item. If they have some you know, dust on their hands that had pesticides in it, they're then transferring that to their food and into their mouth and having an ingestion exposure. And then of course, little kids are, especially these kids are a little bit older, but 2, 3-year-olds, especially 2-year-olds, are putting their hands in their mouth all the time just as a normal behavior. They also spend a lot of time indoors. So if we're using pesticides or other materials inside, they're going to get exposed to a relatively high level. And this is important too, this idea that their brain and their bodily organs and systems are growing and developing very rapidly. So we have a few more slides kind of illustrating this. But here's an example of that higher exposure for body weight. So you'll see here, this is a slide that shows just water intake. And we're looking at the milliliters, or 2.5 milliliters is about a teaspoon. So we're talking about 40 milliliters, we're talking about maybe 15 teaspoons a day or something like that, or 20. But what this graph shows here is that for children who are less than a year old, so really young children, they're getting a lot more water per body weight than older kids. Like by the time they're in middle school and adults, we've pretty much reached our intake range that's the same relative to our body weight. So, but for those very young kids, they're having a much higher exposure. So if you have a contaminant in that water or food, or this also extends to air and things like that, again, young children eat, breathe, and drink more for their body weight. So they're actually getting higher exposures. And this little graph shows that concept for water intake. Next slide. So this is kind of takes that graph and puts it in a visual. And if you look at the red triangle in proportion to the body size of the kid versus the adult, you can see it's much larger for the kid. So this kind of just is a straight picture of the concept we just talked about, and I think makes it clearer. So this is a great tool to convey this concept. Next slide. So I alluded earlier, I said that kids are developing and changing, and again, that's a really important part of their development and why they're more vulnerable. So we have metabolic pathways, for example, that are changing very rapidly. There's some processes in the body that can actually detoxify pesticides, but in very young children, they're less developed, and there's lower levels, for example, of the enzymes that may break down and protect you from a pesticide, whereas the older kid or adult is more protected. So that's an example of differences in metabolism. And I also talked earlier about kind of brain development and learning ability and things like that. And I use this picture of the brain here and the Leaning Tower of Pisa as an example. We all have kind of a neurological architecture, or a neural architecture. In fact, the process of growing and forming from a little baby, who can't talk and is just learning to make their way in the world, to a functioning older child or adult, we actually develop a structure in our brain that's based on all these connections between our neurons in our brain, and that people often describe that as a neural architecture. So if we have exposure to a neurotoxic chemical, when we're very young, you may kind of shift that development. And I use the Leaning Tower of Pisa as an example because architecturally, it's structurally, it may fall, but architecturally, it's actually kind of intact. All the original rooms and stairs and everything like that is there and is put together and has its original structure, but it's a little bit off. And that's the concern with early neurotoxic exposures to children, that they won't develop into their optimal person because of changes to their brain. And again, problems like ADHD or learning problems that may have long-term impacts. Next slide. So I mentioned this here, the Food Quality Protection Act, because it's so important in both pesticide regulation and regulation about chemical exposures in the US. Back in 1993, there was a report from the National Academy of Sciences, Pesticides in the Diets of Infants and Children. And they did some studies and kind of showed that there could be pesticide levels in food that, depending on the diets of individual children, some may have exposures above health-based standards. And that led to the Food Quality Protection Act, which added some more regulations to pesticide. But one of the really important pieces of this, well, two. One, you had to set standards that reflect the specific vulnerabilities of children. So we can't just have a standard that protects, 18-year-old adults, but rather if there's, we can't allow an exposure that could cause any hazard to young children. So we have to orient our risk assessment and standards to those children. But there's other piece also, when we looked at pesticide exposure, you had to think about dietary and non-dietary sources. So EPA was saying we have to look at the whole pot of pesticide exposure, and we have to think of what's in food and what's also in their environment. And that then resulted in a lot of studies to understand what the non-dietary exposures are. And that led to looking at both residential environments. And then, Abbey Alkon many years ago kind of pioneered taking this concern about non-dietary exposures, not just in homes, but also looking at school and especially childcare environments where children spend a lot of time. And we know there's also regular pest control needed and use of pesticides. So that's just a little context to some of the history here with the policy. Next slide. So I think
Thanks,
Abby,
Asa.
shifting over to you. Thanks.
Thanks. So I'm going to talk about the actual study that we did, our aims and objectives. So the goal of the study overall was to reduce the preschool age children's exposure to pesticides to improve their long-term health. So we focused on preschoolers, who are 3 and 4-year-olds. And the study's title was the Healthy Children and Environment Study. And so what we wanted to do was to determine if an intervention that we had, which was led by childcare health consultants, and I'll talk a little bit about, these are trained people who are experienced mostly as nurses and health educators to work in childcare, and they led the intervention. So they provided an integrated pest management workshop, and we wanted to know if that would improve the staff's knowledge. We also provided an intervention led by the childcare health consultants to see if their intervention over 7 months would increase the staff's self-efficacy, increase the number of policies and practices they had related to IPM, and decrease the pest problems as identified by the number of pests present or the debris that we see from pests. And then the last one was the highest level, was to determine if this IPM intervention could actually reduce pesticide exposure in the intervention compared to control centers. And the way, as Asa had talked about, we were measuring objectively what the pesticide exposure was through carpet dust and also the individual exposure through wristbands that children and staff wore. And I'll explain that a little more in the methods. And so our design was a randomized control study, and it had an interesting twist to it with what we call an attention control. And what it is that the counties that we had, we started out with 4 and we added a 5th one because one county was small. But the counties were matched and randomly assigned to the intervention group or our attention control group. So the intervention was the integrated pest management. And the control group or attention control got a different intervention, physical activity, but they had comparable time with our childcare health consultant. They had the same intensity and time for the intervention for both groups, and we had the same measures that we did pre and post. So they were really good comparison groups. We, in the end, finished our study in 5 counties in Northern California, so Solano, Contra Costa, San Joaquin, Stanislaus, and Alameda. And we matched and controlled the counties by being, if they were physically adjacent to each other, the percent of families who were at the federal poverty level, the percentage of children in it. And we also used the pesticide use reporting data from DPR to look at the ratings. For our recruitment, we only enrolled licensed child care centers because they are compliant with our state regulations. They needed to have 3 and 4-year-olds in their classroom, and we wanted some stability in the centers, so we wanted to make sure that they had been operating for at least 1 year and would be continuing to operate. To do our dust sampling, we had to make sure that they had a carpet in the rooms. We didn't actually need to go to fabric on the furniture, we only used carpet. And we also wanted a diverse group of children and families, so we wanted to make sure that at least 25% of the children were eligible for some subsidies like CACP or Medi-Cal. So in the end, we also wanted to not only enroll centers, but also individual children. So we recruited the families who were enrolled in the center. And if the families had a child who was 3 to 4, that they were going to be in the center at least 30 hours a week, because we wanted to make sure that they had ample exposure, to be enrolled in the center for the 9 months that we were doing our study, and that they would complete a family survey. We also had childcare providers enrolled in the study, and we wanted at least one provider for a classroom, that we were really focusing on one classroom. And we wanted the provider to wear the wristbands just like the kids. It was a great role model for them and a great way to get the data for both the adult in the room and the children. And the providers completed some surveys for us too. So everybody who was in our study was reimbursed by their time. They received gift certificates, and we provided $250 for our directors, and they also got a lot of other things. They got an IPM toolkit, toolbox. We gave them lots of resources. We provided workshops. Our providers got $40 gift certificates, and parents got $30. So the intervention itself, as I mentioned, was led by a childcare health consultant. And this is a health professional who's trained to provide health and safety expertise in childcare. This is a field I've been working in for a long time, and we have national guidelines to provide health and safety guidance at the national level, and it's a little bit higher standard than what we have in regulations in California. And so we always like to have the highest standard, and we like to help the childcare centers reach this higher level that is set by what we call Caring for Our Children, is the name of the book that has all the guidelines, and we call it the Caring for Our Children standards. The childcare health consultant provides educational workshops. They use these national standards to set our goals with our childcare directors. We review the policies that are required by California state licensing. They are written policies that are in childcare centers. And we work directly with the center director every month to set goals and to help them reach their goals. And just to step back a minute and talk about what does a health consultant do and what is our overall goal. And I've been working in this field for 25 years, and we found childcare health consultants can provide different kinds of intervention, but overall there's kind of this stepwise change that we expect to happen when we have an intervention. We always go out and start by doing an assessment. Then we provide the educational workshop. Based on what we find are the gaps in the assessment, we provide consultation services. The first level of change, we hope, is to have written policies that are really appropriate and meaningful for, in this case, integrated pest management. Then we look at the health practices related to integrated pest management. And ultimately, what we'd like to do is to change children's health and improve it. So what did we do? The Department of Pesticide Regulation funded Asa and I many years ago to develop an integrated pest management curriculum for early care and education or child care centers. And so we use this curriculum in this intervention. This is an approach, as you all know about integrated pest management, that focuses on preventing infestations by keeping the pest out and getting rid of the food, water, and shelter, to look at ways to monitor the pests, to help the directors learn about reducing the use of harmful pesticides, and ultimately the reason is to minimize the health risks to the people and the environment. And so what we did was we would give them this toolkit, and in the toolkit we have what we call health and safety notes or pest sheets. We also have fact sheets that they can actually share with families. We give them some posters, and we have a checklist that we use and we talk to them about. We have presentation slides that we share with them, and it's also free on our website. So any of you can use this information, and we'd love you to look at our website and see how to use this curriculum. And this is what the philosophy of the curriculum is really the steps of prevention, inspection, identification, monitoring, and managing. And we have pest sheets, as I mentioned, that are specific to different pests. And based on some surveys that we did, we asked the childcare directors what are the most common pests that they're dealing with. And based on that, we developed pest sheets for them. We also were funded by the Department of Pesticide Regulation to have a toolkit not just for centers, but also for family childcare homes. And then we give everyone a toolbox. And what we say is we want to have something ready for them to use IPM practices when we walk out the door after the workshop. So we give them things like a doormat, caulk, a door sweep, silicone sealants, cleaning cloths, a special duster so that they can reach the spider webs high up, cockroaches, traps, gel, and bait. So we try to give them tools that they can use so they can implement IPM right away. So some of our posters are this. So one of them is about how to read a pesticide label. We know it's a little complicated, and we wanted to try and break that down for people. We also talk about how to store pesticides if you have them on site. And according to our regulations for childcare, they have to have a material safety data sheet on site for each of the chemicals that they have. They also need to make sure that the substances are not accessible to children and stored in a locked cabinet. And if they use bleach, they has to be labeled with content and date mix. So some of these things are what we look for because these are part of our California state regulations. We also give them information about hiring a pest management professional. And you'll see from our data, it's very common for directors to be working with pest management professionals. And we give them guidance about making sure that they're licensed, that they're trained in IPM, and that they might have third-party certification. So in our study, as I mentioned, we have baseline measures and post-intervention. The full intervention itself was 7 months. So on the left-hand side, you can see the measures that we use for our baseline, which were interviews. We go out and do our assessments, which are the environmental checklist. We do our dust sampling. We also have 5 children in each classroom wearing the wristbands along with a teacher. And we observe activity and do children's heights and weights. During the intervention, we start with a workshop and we review the results of our assessment, set the goals with our director, and meet with them monthly. And post-intervention is basically the same as the baseline. And so this is Kim Hazard here collecting dust with one of our very fancy dust vacuum cleaners. And we set out about 3 square feet and we collect enough dust that we freeze and then send it to the lab at Southwest Research Institute. For our wristbands, they're silicone wristbands that are from Dr. Kim Anderson's lab in Oregon State. And they are cleaned so that when they're put on the child's wrist or the adult wrist, it absorbs what is in the air and on their skin. And they wear them for 30 hours in the childcare center. And we had 1 year where we also had the children wear a different wristband at home and in the center. We keep a log on when the wristbands are on and off so we know how many hours we've gotten this exposure. So this is a list of the pesticides that we measure, and Asa, maybe you can go through what these are.
Sure. Some of you may be familiar with these. A number of them are products that you might see used more often in an indoor environment for a structural environment or structural pesticide use, especially several of the pyrethroids and fipronil and the chlorphenapyr. Sorry, note there. Those are probably familiar to many of you. And then we've also included some of the older organophosphate pesticides. Most of these were eliminated from indoor use, over 20 years ago, chlorpyrifos and diazinon. But we actually tend to still see them indoors. And there's also been more recent agricultural use, especially for chlorpyrifos, diazinon, and malthion, of course, is still used in agriculture. So in many of our childcare facilities, we're in areas where, of course, there may have been structural pesticide use going on, but also the potential for drift or some other source coming from outside. So again, the chlorpyrifos and diazinon are kind of legacy pesticides, and malthion, though, is really not used indoors, but still has agricultural use. That one up on the left, dactyl, is an herbicide, and we kind of put that in as kind of a negative control. It's really only used in agriculture, and it's also mainly used in the Salinas Valley, is where some of the most heavy heavy use has been related to greens production. So it has less agricultural use in other regions in California where there's more vineyard and orchard agriculture, tree orchards. So, and again, just to say one more thing though about those pesticides, many of them are neurotoxic. All the organophosphates are, and that's one of the main reasons why they were phased out, especially for indoor use, because of concerns about neurotoxicity in children. But all the pyrethroids are also the mechanism with which they kill bugs and are toxic to people also involve impacts on our nerves and neurology. So there are some of the main pesticides we use are neurotoxic. The pyrethroids, though, tend to be less toxic than the organophosphates, but they still raise some health concerns.
Thank you. So the results are that we enrolled 85 childcare centers, and it was over about 6 years because of COVID to slow things down a little bit. So let me just run through a little bit about what we found and who was in our study. So in terms of childcare centers, we had a range of centers from nonprofit to for-profit, Head Start, California State Preschool. And on the right-hand side, you can see the size of the childcare centers were mostly pretty small, between 10 and 50 children in a center, but some of them were also large, about 50-50. The director's experience, the average was about 22 years. So we had quite an experienced group of people in our study. In terms of the staff ages and the director's ages, again, pretty experienced people in about their 40s. In terms of race, ethnicity of the directors and the staff, and the left-hand side where the directors are, we can see that we had a largest percent was Caucasian, 41%, 30% Latino, and it's about 17% Black or African American. And the red is mixed race, which is 5%. And what's interesting on the staff and the ethnicity for them, or the mixed race, is about 11%, and Latino is larger, 43%, and Caucasian is 27%, and African American is 10%. In terms of education, we expect to have the directors in California they're required to have about bachelor's degrees. So the majority of them had a bachelor's degree or higher, and staff education was mostly some education, mostly like a community college and associate degree. In terms of the languages spoken for in the centers, the green here is English and other languages, and the blue is 28% is only English. And we asked the families at home, did they speak English or other languages? And you could see on the right-hand side, 53% spoke only English, but 39% spoke English and other languages at home, and 5% was only Spanish. In terms of the race, ethnicity of the parents and the children, it was quite mixed and not surprising in the counties that we were in. And so for the parents, 28% was white and 26% are multiracial and others. And then on the right-hand side, the children's ethnicity, it was 23% white, but multiracial is up to 34%. And Latino is 10%, and Latino white is 14%, so together 24% Latino. In terms of the families, we asked them some specific questions, and we asked them if only English was spoken at home, and it was 54%, 33% had subsidies, and 81% had someone employed in the household. So the majority of them were employed. We asked them about some environmental health practices, and we learned that 56% had a doormat outside their front door, 55% had carpeting, 32% said they cleaned their floors daily, 16% had mold visible, 10% lived near agricultural fields, and 5% had someone working and actually had said that they applied pesticides in the last 6 months.
Can I also say something
Sure.
a little bit more about that slide? Just mentioning some of these, like the idea of a doormat. Interestingly, there's been several studies showing that homes with a doormat, people wipe their feet or even take their shoes off before they go inside, there tends to be less pesticides in the home. If they're in an environment, for example, where pesticides are used, or an agricultural environment, or working in the fields. So that little question and that bit of information actually can be quite important for exposure. There's also been similar studies with lead and lead dust and in lead paint dust and things like that. So there's that's part of the reason why we ask these kinds of questions, because cleaning practices and just having a doormat can actually make a difference in how much contamination is inside a home.
And that's actually one of the reasons that we include a doormat when we do our workshops. We would like to give the director a doormat because we want to make sure that they have them, because not everybody has them in their childcare centers. And so when I mentioned some of the objectives, when we do our workshop, one of the things we'd like to see is an increase in knowledge about what integrated pest management is, and also overall people's sense of self-efficacy. So let me go over that. So what we found was an increase in knowledge for the people who attended our IPM workshop. And they were filled out a survey, and their knowledge was statistically significant, and improvement from 77% to 93%. And just to give you a flavor for what are the things that we ask things about what is the Healthy Schools Act. We asked them about what the approach is to IPM. What are 3 things that we do to help the pest survive, so that we would be focusing on those for IPM, and how can mold make people sick, and which pesticides pose the least health risk for people, and how do you practice IPM indoors, and how do you prevent pests from entering your center, and how often do you need to mix the bleach. So the next level was we were looking at something called self-efficacy. And in childcare in particular, it's really an important concept for the directors and the staff to feel empowerment, to feel like they have some control over the environment, over the things that they're doing, and that they feel positive about working with the children and the families. And so we hope that our intervention provides just overall support for people who are in our study. And that's why we do it over 7 months. We want to have a relationship. It takes time to develop trust. It takes time to really understand what the needs are for each childcare program. They're all individuals, they're all different. And so we have questions, or it's comments that we make, and we ask people to rate them from low to high. Things like, I can make the childcare center a safe place for children to play and explore. I can help the children in my center learn healthy habits. So these are general comments that we actually are expressing because we feel like this intervention is more than just IPM. It's also making people feel empowered. And I'm very happy to say when we looked at our results that all of the centers in this study improved their self-efficacy from baseline to the end of the intervention. And what it also shows is it didn't matter if they had a physical activity intervention or IPM. Just having this childcare consultant over the 7 months, providing support, meeting with them every month, improved their sense of self-efficacy during this study. So what had happened with policies and practices? In terms of policies also, as I mentioned, it's required for centers to have IPM policies, and we help them writing those policies if they don't have them. And we were able to see a very strong improvement in the intervention centers having policies before and after the study. In terms of this IPM checklist, this is something that I developed over the years and we've been using for many years in childcare. It's a way of doing an objective assessment of the environment by spending about 1 to 2 hours just walking through the environment to look to see how they're vulnerable to pests and how they can use IPM practices to reduce their exposure to pests. And what we see here very strongly is the centers that got the IPM intervention compared to our control centers had a strong improvement in the practices that we observed during this assessment. And there's absolutely no change in the control centers. And that makes sense because they didn't get an intervention specific to IPM. They got a physical activity intervention. So we're very happy to show that the IPM centers really can improve when you focus your intervention specifically on IPM. And so just to give you a flavor for what are some of the things that we are looking for, what are some of the IPM practices that we're monitoring. And we look physically in different areas of the center. So in common space, play areas, and eating areas, we're looking to see that the furniture, flat surfaces, and floors are free of dust. We're looking to see that the garbage containers have lids, that the walls, windows, and ceilings are dry without mold or water damage. When we go to the storage areas, which are really important in childcare, there's a lot of things that they store that they don't keep out all the time. We're looking to see that they're clean, organized, and free of clutter, that their buckets or rinsed and mops are hung up to dry. In the bathrooms, we're trying to look at the walls, the floors, the tiles, because we want to see that they don't have holes, gaps, or cracks. In the kitchen, we're looking at the gaps between pipes, vents, and walls are sealed and screened. And just the reason I picked these items here to talk to you about is that these are the ones that actually significantly improved in the centers that were in the IPM group. And so we were really happy to see these changes. And I see there's a question. Please, Melissa, go ahead and ask your question.
Sorry, that was a mistake.
Oh, okay. Okay, just want if anyone has a question, please raise your hand and we'd love to entertain it as we're going through. So another question we had that we asked people in our interview is, do you work with a pest management professional? And what we found from the families was that 30% said that they did work with a pest management professional. When we asked the center directors, it was very different. 86% had a pest management professional that had been there in the last 12 months. So this is a large percent of our centers. Then we asked them, if you had a pest management professional, how often did they visit? And the frequency here is at least yearly was 53%, but monthly is 11%. That's the blue. And 61% of the centers had a PMP that sprayed pesticides in the last 12 months. So that's the blue part here. So that's what we were interested in. Are they spraying? How often do they come? And then we asked the directors, do you know what they sprayed? Do you know why they came? What happened? And the majority of people do not know what they sprayed. And so we actually asked to see the documents so that we can actually understand what is being sprayed, because many times they don't understand what it is, but they just know that they had a problem and they wanted to get rid of it. So what were the pests and the products that we saw when we went to the centers? And so indoors, we did observations, as I mentioned, with this IPM checklist. And what we saw the most common was spiders. The next most common was flies, 25%, and then some others. And not surprising, outdoors, it was spiders and flies, but also many, many, many other pests that we saw outdoors. When we look at the number of pests or evidence of pests in the IPM centers, we saw a decrease based on our intervention. And in the control centers, we actually saw quite an increase in the number of pests that we saw before the intervention at baseline compared to post. And we also looked at products. So we looked to see what we could observe when we open up the closets, and we asked the childcare directors to have access to their closets to see what products they had. And we are listing here the pesticides that we actually measured in the dust and the wristbands. We looked at the active ingredients of the products and wanted to see how many products they had that contained these pesticides. And as you can see at pre-intervention at baseline, 17 of them had those products. And post-intervention, 7 months later, only 8 of them were on the shelf. But when we came back 1 year later, which is 1 year from pre-intervention, the number of products was about the same. And this we know could have to do with seasonal issues because the pre-intervention was pretty much in the fall, post was in the spring, and 1 year later was again in the fall. So these are some of the products that we observed, just to share in terms of the names and the types. They are quite a range of different ones that people use. Some are baits, some are granules, a lot of them are sprays, and that's what we've been observing. So in terms of our results, we looked at our dust samples, and we look at detection, and then we look at concentration. And I'll have Asa start with this, sharing these histograms with you.
Thank you. So what this graph shows are the detection frequency of several of the pesticides we tested for. So these were ones with significant detection frequencies. And what this means, say, let's just look at fipronil on the left, it means that about 85% of the childcare facilities had fipronil in the dust in the childcare center. And then if we go to the right, all the way to the right, you'll see that the lambda cyhaloethrin, which is a pyrethroid, it was about 40%. So, and then you see kind of the range across the slide, and you'll see that many of those are actually pyrethroids. Although you'll see in the middle there, chlorpyrifos was also detected, 60% of the time. And in California, that's actually not used in agriculture anymore, and many years ago was prohibited from indoor use. So this could be possibly, infiltration from more recent agricultural use, or, one issue with contaminants, especially pesticides in an indoor environment, there's relatively little, moisture or sunlight or soil, the things in the outdoors that tends to break down pesticides. Pesticides can be broken down physically, in some cases by sunlight, by temperature. And then there's also lots of biological activity that goes on in soil and things like that. And so you add some rain, some moisture, and some sunlight, and pesticides tend to, those that do break down quickly often do outside, but some of those same pesticides indoors will persist for much longer. And we believe that chlorpyrifos is one of those. In the indoor environment, it's really acts more like a persistent pesticide rather than one that breaks down quickly. But the general theme here you see is that there's lots of pyrethroids, and then also fipronil, which is in a different class, and that piperonal butoxide is often used as a synergist with pyrethroids. So this is kind of a profile that's pretty characteristic of structural pest control use. But then also there's, some of these materials, although they might be primarily used for structural, some of the pyrethroids, for example, also have registered uses in agriculture. But I guess the last thing to say about it, and we can actually, look at this slide for that too, is that, virtually all the centers had at least one pesticide detected. So, you walk into an indoor environment, you tend to see at least, there's some pesticides in that dust. And we know, for example, I mentioned from lead studies that if there's pesticides in dust, it's also getting into children. So on the right, you'll see some of the detection frequencies post-intervention. And, surprisingly, we see some of these detection frequencies that actually increased, which is not what we probably would have hoped for or expect. And that's, one of the challenges with doing research is, you got to report what you find. And this could be due to, use that went on in the facility. It could be also due to seasonal differences or agricultural use. There might be some infiltration going on here from outside the facility, even potentially, a nearby outdoor use. So just some of the challenges here with research, and surprisingly, I guess to say, when you do science, you don't want to drive your outcomes by what you hope for, but that's why you have to report the numbers. But we'd hope that this would have gone down more on the post-intervention side. And but we look at another group a full year later. So if you remember, that post-intervention period was less than a year. So again, there could be seasonal implications there. But when we look a full year later, so a full cycle, we do see some decreases for several of the pesticides. And again, by decreases, we're talking about detection frequency. In other words, it was less often detected in the facility. So here now we're talking about concentrations. And often when we talk about exposure, For example, there's formulas you can use to estimate if you have pesticides in dust. EPA, for example, has formulas like we expect that kids eat about 30 milligrams of dust a day. So it's a way to estimate calculations. And by looking at the actual concentration here, not the detection frequency, we can do some work, for example, estimating exposure and getting a sense of the magnitude of contamination. In fact, Kim Hazard, I think she may have left, has worked with this data to try to understand what the exposures and risks are. But you'll see there, for example, there's a wide range of concentrations. On the left, you see cypermethrin had up to 1,000 nanograms per gram, or that's about a milligram per gram. And then the range down to chlorpyrifos, which even though it was detected quite frequently, the levels were fairly low, which makes sense given that it's not used indoors and even in agriculture right now. You'll see fipronil had a slightly lower concentration than some of the pyrethroids, but fipronil had one of the highest detection frequencies. So when we look at these kinds of data, you get a range of both concentrations and levels, and it gives you a sense of what the magnitude of contamination is. And also for risk assessment purposes, we can spend some time estimating what may be going into a child's body. So when we look at the concentrations, we had this same issue post-intervention where there were some increases for some of the pesticides. And again, that's something we don't quite understand, and it could be related to seasonal changes. And then there could be the same issue there where many of these pyrethroids, although they're primarily used in structural pest control, there are agricultural uses. And this is one of the challenges California is facing. I remember meeting with an agricultural commissioner, and with the taking out chlorpyrifos off the market, I think there are actually good reasons to do that because of concerns about exposures to chlorpyrifos. But one of his points was that for each spray of chlorpyrifos, for example, we were talking about a particular pest on walnuts, that you'd have to replace with 4 sprays of a pyrethroid. To me, that targets a pest problem that we need to really develop some good integrated pest management approaches. And with those same sort of challenges, of course, are indoors. So again, this is post-intervention, not a full year after, but there were some changes that we didn't expect. Next slide. Although when you look at the concentration a year later, many of them were similar to what they were a year before. We expected to see reductions, but we do at least see for one of them, bifenthrin, which is a common structural pesticide, that it did go down. And that is one that's actually commonly used indoors. So at least for that one pesticide, it did kind of go in the direction we hoped for. And some of these other ones, you'll see, for example, fipronil is also significantly, is also lower. But we highlight the one in green here because it's what we call statistically significant a year later. And that's when we get into kind of the nuances of research. You'll see that the concentration of fipronil, was 100 in a year later and was, close to 300. But we don't see the same statistical significance because of the number of samples and that sort of thing. But at least we didn't see a trend here in concentrations a full year later of increasing concentrations. And that post-intervention period, which is kind of mid-year, so it may be off cycle not on cycle with the initial measurement, and maybe there's some other factors going on that are influencing contamination at different seasons that are not accounted for until we look a full year later when the sample collection was done at the same season. Next slide.
Thanks, Asa.
Okay, thank you.
Yeah, so I'll do the summary and then have you come back for the next part because it's similar. So
Sure.
Just to say, what we actually found was when we compared our IPM centers with our control centers, there were no differences in the concentration. And as you know, that I mentioned, one of our goals was to hope that our IPM intervention would actually decrease the pesticide exposure. In fact, in the objective measures that we have, the way we've analyzed it so far, we don't see the difference between the centers. So we're trying to understand a little bit more about that. But we did see that there was an overall increase at 7 months. And then there were some decreases a year later. So we're trying to explore this a little bit more to understand what's happening in terms of the seasons and what's different with looking at things 1 year later. And so now we're going to switch to look at our wristbands, which I mentioned was 5 children per center wore these wristbands. So we have a lot of data. 393 children participated in this part of our study. And I'll have Asa go through it again. We have our detection and the concentration. So go ahead.
Thank you. So this is just really interesting. I mean, Abby introduced these, and so these are like the little silicone wristbands that you might see at an amusement park or something like that as an ID. And this scientist, Kim Anderson in Oregon, discovered if you like soak them in a solvent or alcohol, you can basically take any contaminants out of them. And then when you put them back in the environment, things like pesticides that touch it gradually get absorbed. And so you can then measure those pesticides in the wristband. And you, of course, have some controls that were perfectly clean. So you make sure that there were no contaminants ahead of time. And you can see here that many of the pesticides that we measured in the dust, we also found on these wristbands, which further confirms that these are on kids' hands and that kids are getting exposed. It's actually kind of a measure of what's actually contacting the kids. And you'll see, again, a lot of pyrethroids here. You see fipronil again. In this case, cypermethrin was one of the most frequently detected, up to 35%. And also chlorpyrifos was present. So these kids are getting exposed to that chlorpyrifos in their environment. And this is really kind of pioneering work. I think we're one of the first groups to look at this in childcare, but it confirms that what's in kids' environments is also what's contacting the kids' bodies. So again, we had some changes here with the wristbands. And again, this is about exposure because the kids are wearing these. And you can see that for some of these, especially the green columns, we look at detection frequency, they tended to decrease, several of them. So that's reassuring that maybe some of the IPM practices that were implemented did reduce exposures. And if you remember, we did successfully increase integrated pest management practices. So here we're trying to take that behavior and see if it relates to some of the concentrations of the chemicals we're interested in. So next slide. And then here are the previous slide was the detection frequencies. Here we're looking at the actual concentrations. So the concentration again is the mass or the nanograms or milligrams of the actual pesticide that got absorbed. And you can see that's really dominated by the pyrethroids, which are the primary indoor structural pest control chemical that's being used these days. So again, the permethrin, bifenthrin.
Sorry, yeah,
no,
I just jumped the gun, but here's the post. Go ahead.
Yeah. So you can see from the post of these that several of these went down. Bifenthrin actually went down substantially, and so did cypermethrin. And if we look at the cis-permethrin, that went up a bit, but it wasn't statistically significant. So this tend to show, especially for the pesticides with the the highest concentrations, that there were some reductions, and likely indicates that the kids, we still detected many of these pesticides, but the magnitude of exposure may have gone down. Next slide.
Thanks. So this is our summary about this again, and what we found is something similar with the dust, where there is no difference between our IPM centers and the physical activity or control centers. So the results that we gave you was over both of the groups, what do we find in general? So overall, we did find an increase in bifenthrin, cypermethrin, and chlorpyrifos during the 7 months. So we know. Yeah, go ahead.
I will say though that over the year though there were some decreases as well.
Right. Yeah. And I think that because we didn't find a difference between the IPM and the control centers, we wanted to just maybe step back a little bit and say, maybe we should look at also what predicts the concentration of the pesticides. And so we published 2 papers on this, and we looked at this in the first 3 years of our study, and we're now trying to validate that with our full 6 years of data. But we did find that if you look at just the baseline pesticide concentration, there were some factors that were associated with higher concentration. One being if the childcare center is located within 3 kilometers of the agricultural field, if they did have a PMP spray in the last year. And then we also did an observation of the children's behavior. As we talked about integrated pest management, one of the things we look at is, do the kids wash their hands regularly, which is not something they're in charge of, but is up to the providers to remind them and to provide the place for them to go and wash their hands. And in the centers where kids wash their hands regularly, according to what our national standards are, they actually had lower concentrations of pesticide. And then we also saw it with our integrated pest management observation that we did our practices. If they had a lower score on that, they had higher concentration of pesticides. One thing interesting, places that we saw fewer pests, they had higher concentration of pesticides, and maybe they had less pests because the pesticides worked and they were using more pesticides. So that was something that we didn't expect to see, but we did. Another thing that we found, and Kim Hazard is actually a person who looked at this in particular, the carpeting that we were sampling was always a carpet where the children spend time in what we call circle time, where they spend time in the morning. But some of those carpets are sitting on wood flooring or a laminate flooring, and some of them are on wall-to-wall carpeting. And we were trying to understand if there's a difference in the concentration based on where that carpet is located. And we found if it was located on a hard surface floor versus a wall-to-wall carpeting, it had higher concentration of pesticides. So in summary, we found that the childcare providers improved their knowledge, the providers and directors increased their self-efficacy, there were positive changes in our observation of IPM practices, and we found 5 pesticides in particular that was higher detection and concentration in both dust and wristbands, which bifenthrin, cis and transpermethrin, chlorpyrifos, and cypermethrin. And there were no significant differences, decreases in the exposure that we were hoping from the post versus the pre-intervention for our IPM versus our control centers. So we always like to end with some positive note when we are giving these presentations and talking to childcare providers and to families. And we wanted some take-home messages that are based on our data and based on other people's findings that we know are in the literature. So the things that we try to say as our public health messages, making sure that children are washing their hands because we do see that it decreases the actual concentration of pesticides for those centers. We know that ventilation, opening windows, changing air filters on air purifiers is a really important thing. Cleaning the environment, we give them microfiber cloths. We talk about using a HEPA filter vacuum cleaner and annual deep cleaning. We really try and get the concept across between separating the outside and the indoor environment, and that goes back to our doormats. It's really important to give them a way to think about how to separate the two. What can you do? And we also talk about the parents washing and separating their work clothes if they are working in the fields. And if possible, a no-shoe policy is really good. That's usually used in infant toddler centers, but not as much in the preschool ages. Our big message is don't use sprays, and we try and give them alternatives to thinking about what to do instead of using sprays. And we also know overall a healthy diet is important. And so some of the also information we give people is to understand what are these pesticides that we're talking about in childcare. These are new words for them. It's a new language. And we try to explain why they're used, what if they're an insecticide or an herbicide or organophosphate, what they are. So this is some information that we share with them. So we also know any study that we have has some limitations and lessons learned. And as we were alluding to, there are some seasonal changes that we're seeing in our data. But we're also concerned about long-term effects of pesticide exposure. And this is only a one-year study, so we were not able to measure that as much as like the Chamaco study did that Asa was involved with and I was involved with in the Salinas Valley. We also know that it's hard for directors to make change in their practices because sometimes they don't have control over it. It might be the facilities manager, or it might be the PMP that's really in charge of monitoring what the pesticides are that they're using. We also know we didn't have enough power for everything because of COVID-19. We lost some centers in the post-intervention period. We also learned that it would have been good for us to report back results to the childcare directors in terms of what pesticides we found in their centers and then focused on that for the intervention. We weren't able to do that in this study. So we've actually we have a new study that was just funded that will be including reporting back results before we actually start the intervention. Just want to mention, I was very honored to be interviewed by NIEHS, and they did a podcast on these results and what we're doing today. And so I'll quickly just mention that we have a new study that is going to be not in centers, but in family childcare homes. We're now focusing only in the San Joaquin Valley because we know that there is higher concentration of pesticides that we found in the centers in San Joaquin Valley compared to the Bay Area. And so we're trying to change the way we did the intervention and look at the best practices for returning results directly to the family child care home director as part of the intervention. So I'll just quickly show you what we're doing. We're doing a mixed method study. We are focusing on county-based stakeholders, and we're talking to family child care home directors, and we're using an environmental justice framework where we start the first year by just talking to people in the community and then developing the intervention. So we're working in San Joaquin, Stanislaus, Tulare, and Fresno. And we're going to be developing a way of reporting back results as part of the intervention. And then in the end, what we learn, we're going to disseminate and create a policy. So what we're doing in our first year, which is right now, is we've met with 30 stakeholder agencies. We've met with family child care home directors, and we talked to them about our findings from this study and tried to understand what it would mean for their community and how to report back results. And then we're going to do a 2-year study in family child care homes, including reporting back results, and go back to the stakeholder agencies and develop best practices and policies. And I thank you for your time today, and we're open for questions and answers.